Hi, my name is Dr. Murray Arlen, and I'm a periodontist from Toronto. I want to thank David Garber and Dental XP for inviting me to do this presentation. And our first presentation of a series that we're working on will be on narrow diameter implants. Let me start off by showing you a case of a young male and about 20 years old, actually a best friend of my son. He had gone through extensive orthodontic treatment for many years. He had congenitally missing lateral incisors, and the best the orthodontist could do was to provide a small space for the right and even a smaller space for the left lateral incisor. What I'm showing you here is actually the final restoration, and perhaps you can already have an idea of which maxillary lateral incisor is the implant, which is the restored with actually a Maryland bridge. And my proposal to you is, if it was your mouth, which would you rather have? The implant restoration with a narrow diameter implant of necessity on the upper right lateral versus the Maryland bridge on the left. There are many issues to consider. There's, of course, the aesthetic issues, hygiene issues in terms of being able to floss without having a fused contact. So this is the patient's right side with the single tooth implant. There's the left side with the Maryland bridge. We see a difference in color as well because, of course, the Maryland bridge has a metal structure that perhaps some of the gray shines through. And of course, hygienically, the single tooth implant is a much easier restoration to keep clean than the right. So this was just one example, but when we look at narrow diameter implants in general, and the maxillary lateral incisor is a common one, we often have to use narrow diameter implants. And there are a variety of different narrow diameter implants, and by narrow diameter, I'm going to define that for the purpose of this presentation of something of 3.5 millimeters in diameter or less. So if you look at this case, we did manage to squeeze in, so-called thread the needle, with this 3.5 millimeter implant, but really we got lucky a little bit because we really had very little room to spare. And in actual fact, at that time, I didn't have in my armamentarium a narrower implant than the 3.5, and I think a narrower one really would have been a little safer. Although we did get a very acceptable result with this, both functionally and aesthetically. Now, those of you who have been around as long as myself and David Garber and have as much gray in your beard and hair as we do, some of you will remember that we used to sometimes cement in the definitive abutments, as you see in this case. This was the core vent system, and this was a cemented abutment, but the implant itself was a 3.25 millimeter microvent, it was called. It was a titanium alloy. It was reasonably strong, but it was quite narrow, and it did allow us, when we had limited room, whether it was mesiodistally, in this case we had room, but often orofacially we have limited bone, and patients don't always want to go through bone grafting procedures. So very often it's nice to be able to manage with this narrow implant, and it was 3.25. There are other companies that have made available narrow implants. 3i, for example, in this case, we're looking on one side at the standard 3.8 millimeter external hex implant. On the other side, we didn't have the orofacial bone width, and we went to their 3.25 micro mini. Now, this is a two-stage or two-piece implant external hex, and this is the case clinically. On the patient's right, we have the 3.8. On the patient's left, the 3.25. And in many cases, this got us out of trouble, allowed us to do a simple case. Again, historically speaking, and we should know our history or we're destined to repeat it, there have been other implants on the market of narrow diameter. This is a 3.25 external hex, originally with the Stereos company, and this was a machined or turned titanium implant, but it was titanium alloy. And again, it actually was quite a successful implant, and I will show you some long-term statistics afterwards on the long-term success and survival of this particular implant. Now, don't ask me why this restorative dentist splinted this to the adjacent central. I will show you this case a little later in the presentation in more detail. We'll readdress this. And again, just to let you know that as a periodontist, I work with the team approach, and I help diagnose and place the implants, but I do not do the restorative work. So I am working with a multitude of dentists, really for the most part general dentists with various levels of experience, and I'm going to show you real private practice type cases. I haven't really pre-selected just the perfect cases to show you. We're going to see the good, the bad, and the ugly, because I think it's important that we reflect what is real private practice conditions and experience out there. This is a newer narrow diameter implant on the market, the newest. It's actually the smallest two-stage or two-piece implant on the market now from Astra 3.0S. It is 3.0 truly in the body and also at the prosthetic table. There are other implants that call themselves 3.0 that are really 3.2. So this is new. Time will tell if we have any difficulties with strength issues with this narrow two-piece implant. We have started using these and we'll have to wait longer term to truly evaluate their long-term strength and capability. Actually, on this presentation, the implant we'll talk most about is a one-piece implant, which is 3.0 in diameter, and it's the BioHorizons 3.0 one-piece. We'll discuss in more detail how we can go to these narrower diameters without giving up the strength if we have everything in a one-piece or one-stage system. By that I mean the abutment and the implant are all one piece. Now there are advantages and disadvantages of that, which we're going to go into. So here is one case that I did about 4 years ago showing a very successful result. But how narrow can we go? This is a 1.8 millimeter diameter mini implant that some are using not just for overdentures but for fixed type crown and bridge cases. And you'll see that we'll look at the strength of these implants and to know that these implants, it's really unknown long-term with metal fatigue if these kind of implants are going to stand up over time. In this particular case, certainly cosmetically, we achieved a very nice result, but this is not what I would call mainstream implant dentistry, and certainly if you do any of these type of off-label type of cases, you really need a very good patient-informed consent. Let's look at the strength issue a little bit. The little mini implant I just showed you is similar to those last three on the list you see in front of you in terms of strength. If we go back to the BioHorizons 3.01 piece, we see a value of 648 newtons. And we know that that's in the range of implants that do not have a history of fractures. For example, the one just below it, the 3.3 narrow neck Straumann implant, does not have a history of fractures. This is the narrow neck, not the regular neck, and the BioHorizon is stronger than that. But when we go down to those mini implants, we're down to about a third of the strength. We're going to come back to this slide in a moment because we're going to be showing other implants, and I think knowing the strength of what we're using is really important. So let's first discuss the benefits and concerns of one-piece implants, and then we're also going to discuss the benefits and concerns of narrow diameter implants. So let's first discuss what are the primary benefits of a one-piece implant. And by that, once again, I mean that the abutment and the implant are one piece and it's not a two-stage implant. So I'll refer to that as a one-piece implant from here on in. Well, the primary benefits is compared to a two-piece implant with a separate abutment of the same material and diameter, the one piece is much stronger, so less of a fracture risk. We have the elimination of that micro gap where the normal in a two-piece implant where the abutment joins the implant, we have that micro gap, and we know that there's always some bacteria there and there's some inflammation which causes some bone loss and bone remodeling. Perhaps that's what people call the biological width. So with a one-piece implant, the elimination of that micro gap perhaps will have better maintenance of crestal bone levels. So with the reduced crestal bone loss, that could be an advantage. Of course, there can be reduced cost because you don't have to purchase a separate abutment. And it can be conducive to immediate restoration. And I use the word conducive because that can be looked at as a positive if you want immediate restoration. But on the other hand, when you look at the concerns of one-piece implants, conducive, you can change that word to committed to immediate implant restoration. So sometimes we don't want to restore the tooth immediately, but yet if you use a one-piece implant, you've got this big long post sticking out of the gingiva, and if it's in the aesthetic zone, you're kind of forced into it, or you're forced to take out the implant and abort the procedure. you're usually committed to direct restorative. And by that I mean if you prepare that fixed abutment in any way, there is no analog that you can use to do an indirect procedure. So you're forced to do post and core, crown and bridge type dentistry, which some people like, but some people feel the indirect approach is actually a much more elegant procedure. Now, as I say, as a periodontist, I work with the team approach, and I must tell you that in day-to-day practice, it takes more time and effort and coordination whenever we do an immediate restoration, because we have to plan with the restorative dentist in advance. As the patient leaves my office, they're going to the restorative dentist. They have to have the time set aside and the temporary components set aside to be able to do the case in a coordinated fashion for the patient. And of course, as an example, if for some reason we had to abort the procedure, we call up the dentist with very last minute notice saying, you know what, we didn't get the implant in all that time and all those components you ordered you can't use. So you can imagine in private practice, this takes a little bit more effort and coordination for any kind of immediate restoration type of technique. Here's the biggie, limited abutment modification. And that's related to limited accepted implant position. If that implant is not a bullseye and you have to start doing a lot of abutment modification, if you have to do too much modification, there's not enough abutment left to restore the case. So that's the big concern, and we'll look at that more as we look at cases. And related to that, because it's so important to have good implant positioning, you don't want to cut corners and go without an implant placement guide. Even on a single tooth case that you feel you normally wouldn't need one, if it's going to be a one-piece implant, you should have one routinely. Now from one-piece implants, let's look at narrow diameter implants more as a general subject, and what are the benefits and what are at least the primary benefits and primary concerns as it relates to using narrow implants compared to the wider diameter implants. Well, if we look at the benefits first, if we have limited space, whether that's mesiodistally between two teeth or orofacially in terms of minimal bone availability, and of course we're assuming the patient doesn't want to go through orthodontic separation, doesn't want to have that block bone graft done. And we know when we do block bone grafts, they're not 100% effective. And of course there's a lot of morbidity and time and cost involved. So if we can get the case accomplished without compromise and have a narrower implant and can avoid ortho and bone grafts, everyone's very happy. So those are some obvious potential advantages of using a narrower implant. But what are the primary concerns about the narrow implant? There's more or less two categories of concern, and one would be is, do they work? Are the statistics for survival and success as good as the normal or standard diameter implants? What does the literature show? What does my own private practice statistics show? And the other aspect of it is there a risk for fracture? So let's look at these two in a bit more detail. Let's first look at the data if, in fact, the survival and success is equivalent. Now, this is a very busy slide, but just to explain it, on the right-hand side is just a list of references up to 2006, and then on the left-hand side is a series of prosthetic applications, and with each prosthetic application, I've made the references to that list on the right, which references apply. And suffice to say that in all kinds of prosthetic applications, there are a multitude of studies that have shown similar survival and success rates compared to the standard diameter implants. Now we're going to talk in a moment about the issues with published studies and can they be biased, and let me get to that in a moment. These are more recent studies published really within the last year or so with a variety of different implants, some of them more common like the Straumann narrow neck, but some like those mini implants we refer to. And there are some studies out there showing, at least in the short term, some evidence that maybe they can work too if used appropriately. And I'll come back to that, what I mean by if used appropriately. There's even some unpublished abstracts from the European Academy of Osseointegration from September of 2008, again showing similar good survival and success rates with these narrow diameter implants. Now, I need to take a moment or two on some of my own clinical data. And in the preamble, Dr. Garber referred to this computer program that I have, where I have documented every single implant I've ever placed on a powerful access-type relational database. So They tell me I'm crazy why I do it. I don't know, but it's a labor of love. And I can analyze my data in a very scientific and statistically valid way. And it's not that difficult to do, to analyze that once the data is in. And the data is something I input every day. So let's look over a period of up to 20 years, what my personal experience has been comparing narrow diameter implants to standard and wide diameter implants. And the reason I think that private practice data is so important is the majority of the published data that you see is university-based or often commercially sponsored. There is a potential bias there to report on good results. After all, a commercially sponsored study is really interested in showing we got this fantastic survival rate of 98.6%. They're not so much interested in treating the high-risk patient just because they want to help that patient out. So there can be a bias towards treating the least risky type patients, using the best clinicians, trying to skew the methodology so that they can publish the highest possible success rate. And anybody, I think, who would deny that, I think is maybe not being realistic in my opinion. However, in private practice, we want to give all of our patients the proper informed consent, explain all the benefits and the risks, but most of us will treat higher risk patients as long as they've been given that informed consent. Heavy smokers, for example, many of us will treat with proper informed consent. So we tend to treat more high-risk cases, so I think that our results would typically probably be less than what we have in a very controlled study in a university or commercially funded study. And again, I'm dealing with many general dentists, many who have little to no experience, and that's all part of the package of the private practice experience. So with the computer system I have, that lends scientific and statistical credibility to the private practice environment. And let's just look briefly at some of my personal stats on the narrow implant. On the upper left is that 3.25 machined titanium alloy Stereos implant, which is no longer in production. Nevertheless, I have about 200 of those, followed for up to 15 years. And they actually had about 1.5 points higher success rate than the exact same design, exact same material in the 3.8 millimeter diameter. If we look at other systems, we look at Nobel Biocare, I have used the 3.5 millimeter HA coated because that's on a titanium alloy base as opposed to the Ti-Unite, which has to go on a non-alloy titanium. And I've compared that to the larger diameters, and in fact you see it's about 2.5 percentage points below. So, but there are so many other variables that go into these analyses because, for example, with the 3.5, we use that implant when we have limited bone availability. So typically, when we have great bone, we're not using a 3.5. So maybe it's the bone quality and quantity that can account for a lower success rate in some cases with the narrow diameters. So it's very hard to divvy up all of those attributes. But we have to think about them and know that this is a multifactorial issue. BioHorizons is actually a recent system for me. In the last year, I've gotten very heavily involved with it. We've done so far about 80 of their narrow diameter implants, and so far 100% success rate. Let's move to the upper right with the Straumann system. And again, I have a 14-year follow-up comparing the exact same implant design and surface. And if we just compare the 3.3 intraosseous diameter to the 4.1 or the 4.8s, we have about 1,000 implants, or 11 or 1,200 almost. And in fact, the 3.3 has a bit of a higher success rate than the larger diameters. So used appropriately, and again, I'll emphasize used appropriately, the narrow implants can work, certainly in this example. With the Zimmer system, I threw this up. The 3.5 versus the 4.5 both showed dismal success rates, because this was, again, an implant that's out of production that had, in my opinion, a poor HA coating and suffered a high degree of late failure. So it really had nothing to do with the diameter of the implant. It more had to do with the coating. So it sort of, again, I'm throwing in, there's other factors to consider, and statistics can be misleading if all the information is not divulged. Again, sticking with the Zimmer system and looking at different surfaces once we're on that subject, if we look at their more recent implants with the NTX, the rougher surface, we can see that the success rate is extremely high. So bottom line is, used appropriately, narrow diameter implants in my personal experience can work as effectively, and it sort of parallels a lot of the literature that we've seen. So let's look at the BioHorizon 3.0 one-piece implant, which we're going to spend a good portion of our time on. There was an excellent recent study done by Reddy and co-workers, and they had a 96.7% success rate when implants were followed for at least a 1-year period of time. But they also measured the bone loss, which was only about 0.5 millimeter, and they also measured the papilla fill in terms of the aesthetic results. And in the maxilla, where it counts, they had complete papillary fill in 92% of the cases. So let's move on now. The second concern about narrow diameter implants is there a risk of fracture? And this is something that we do need to be careful of. And I think it's really a combination of not just the amount of strength of the implant, and I'll show you that slide again that compares all the strengths that we looked at before, but it's also inappropriate use of implants. So it's always a combination of knowing the strength of your implant and knowing its appropriate use. Again, when we look at the literature historically, with the original Brånemark, which was a grade 1, fairly soft, pure titanium, it's well known that there was a high fracture rate with that. In some studies, more than 5% of the implants fractured in function, mostly in the posterior. And that was a real concern. And when you went up to the 4.0 diameters, that fracture rate really plummeted down. So if we look at other systems, the original Corvent system, which is now Zimmer, had these internal hex implants. I showed you one with the cemented abutment, screw vents and microvents they were called. And prior to 95, those implants, those hexes, had a tendency to split open if they were overloaded. And I myself placed about 600 of those. Over the last 20 years, I've followed them, and I've had about 9 of those split on me. So, and I know that others have reported and shown, at least anecdotally, the same tendency. Again, this implant after 95 was thickened by 0.2 of a millimeter, and supposedly the fracture rate has gone way down, or is non-existent. And although this is maybe not in use today, we still should know this. As we have new implants coming on board, narrower ones with internal connections, we shouldn't forget our history to know that sometimes it takes 2 or 3 years through metal fatigue for these things to start fracturing. They don't always show themselves right away. Now, the BioHorizon has an internal hex that's compatible with what those Corvent ones were, and I'm told, at least from personal communications from BioHorizon, that they do not have a risk for fracture, or they've never had one. Straumann, we talked about that, the standard and wide diameters, and even the 3.3 narrow neck designs apparently have shown no fracture tendency. But there have been anecdotal reports with the 3.3 regular neck, which is the internal octagon type of attachment. And I'm in fact going to show you one of those cases where it did fracture in a moment. So if we look at guidelines in general for reducing risk of implant fracture, which is more of a concern as we go to narrower implants, especially if they're not titanium alloy, we need to basically use our judgment to load these within physiological limits. And I'll just read off these bullets very quickly to you. We want passive fit of the prosthesis so that all the implants are sharing the load as patients function. And that is also related to having the proper preload in our fixation screws. We want to reduce or eliminate cantilevers, especially posterior cantilevers. Again, in the posterior, we want to limit lateral forces, and we can do that by narrowing buccolingual occlusal tables, reducing cuspal inclines. We want to center the context over the center of the tooth as much as possible on the long axis of the implant. We need implant designs of adequate strength, and this comes back to implant diameter, implant material, and implant design. And we don't want to under-engineer the cases. This is a big mistake a lot of inexperienced dentists make. They'll have one implant in the cuspid and one in the second molar, and they'll say, let's save money and just do this 5-unit splint on 2 implants. So we need them sufficient number and sufficient distribution.